Good afternoon. I'm Dr. Andrea Chisholm, Deputy Director and Chief Development Officer of the Trust, and I'm glad that you're able to join us today for the seventh webinar in our ABEP webinar series titled Cutting Edge of Clinical Suicidology, Effective Assessment and Treatment of Suicidal Risk. Presenting today's webinar is Dr. David Jobes. Dr. Jobes is a professor of psychology, director of the Suicide Prevention Laboratory, and Associate Director of Clinical Training for the Catholic University of America. Dr. Jobes is also an adjunct professor of psychiatry for the School of Medicine at the Uniformed Services University. He's the author of 7 books and hundreds of articles and book chapters. David Jobes is also a board member of the American Foundation for Suicide Prevention, a fellow of the American Psychological Association, and is board certified in clinical psychology. He maintains a private clinical and consulting practice in Washington, D.C. and Maryland. I hope everyone learns a lot over the next hour and a half. Please join me in welcoming Dr. David Jobes.
Thank you, Dr. Chisholm. I really appreciate the introduction. I'm so grateful to the Trust and to ABEP for sponsoring this really important series, and I'm honored to be a part with you today and a part of this really important topic that I feel very passionately about. The goal here is to cover really A to Z what I think anybody should know about clinical suicidology in ways that will be meaningful to your patients, to your practice, and ultimately work in the best interest of your clients, which in this case means reducing profound sense of suffering and ultimately potentially saving lives. So with that, I'm going to share my screen. Let's see how all this goes. I'm going to hopefully work my way through these slides in a thoughtful fashion to save about 15-20 minutes towards the end for questions and answers that I believe Dr. Chisholm will be curating for me. So I need to disclose some conflicts. I have a number of considerations that I bring to the table with regard to working in this area. I have grant funding from the NIMH and from NIAAA and a PCORA grant that I think is about to go into the intent to treat phase. My lab is supported by funding from the Four Pines Fund in Vermont. I receive book royalties from Guilford Press and royalties from Jasper Health. And I'm a co-owner of a training company that focuses on uh, the training of the CAMS intervention. I'm really keen to present broadly and not just my own thing. I will, of course, talk about the work that we do at the Suicide Prevention Lab and about the CAMS intervention, but I'll be talking about all the evidence-based approaches that are effective for our consideration. I'm a co-owner of the Hope Institute. You'll hear about that a little bit later. And because I've done work in the DoD and with VA, when I talk about those entities, I'm talking myself as a private citizen, not behalf of the government. So this is a slide I often use to begin the discussion and to get the wheels turning to thinking about suicide prevention at the broadest level and what goes into it. And I think for our purposes, I really want to zero in on this young man is a person of color. He's hanging on to one of the towers of the Golden Gate Bridge out in San Francisco, and he's surrounded by first responders. And before I really knew about a police response to a situation like this, I thought, what is this guy doing over here? And then why is this guy standing in the back? And actually, a police officer was kind enough to explain to me that in a situation like this, everybody has a role. You don't want 4 police officers trying to get this guy to come back over the bridge. You want one designated person who engages. Another is going to watch for the Coast Guard to actually maybe recover this person if they make the fall. A very small percentage of people survive falling off or jumping off the Golden Gate, but some do. And then there are backup and people that might get involved if the Channel 4 shows up to feature this on the evening news. So it's a metaphor for thinking about all the different players that are part of the suicide prevention efforts in your practice or your clinic or your hospital. Each has a crucial role to play to really do our best to save this young man on the bridge. One of the things I can say is that he's ambivalent because he is surrounded by people who are there to save him. And he is clearly in a very dangerous place. So, as clinicians, we may not be in this particular role, but metaphorically, we can be faced with people who are in very dangerous places. And our response to that speaks volumes in terms of what the evidence shows is effective versus what our history says we should do. And that's a bit of what I want to impress upon you as we proceed today. If you're not familiar with the data or our leading causes of death in the United States, we've just continued to see a steady march upwards of suicide over the last number of decades. You look at something like HIV-related mortality. When I was back in my internship days and early in my career, getting an HIV diagnosis was a death sentence. And then NIMH built in billions of dollars in perpetuity. It may be cut now, I don't know, but to actually attack this issue. And we see a huge drop in AIDS-related mortality. Um, we were excited before COVID because the rates started to decrease in 2019 and 2020, only to rebound and be on the rise again in the most recent years. Our most recent data was the most we've ever had in 2023. So 11th leading cause of death, major source of pain and suffering among upwards of 30 people that are affected by each suicide. So a lot of people are impacted by this issue. One of the things I want to bring to your attention, though, as clinicians, we're very preoccupied with the people that are still living. Not that we don't care about the people that die or the people who make attempts, but as I sort of draw you to this figure of SAMHSA data that's collected on a yearly basis, will continue to be collected even after the Department of Government Efficiency got done with SAMHSA. These data are really important because they speak to a really large population, this population in the blue area, which are those Americans who have serious thoughts of suicide in the 30 days prior to the survey being conducted. Thomas Joyner and I wrote a paper, editorial about this, that the field is very focused on completions, get that, leading cause of death, but a much bigger problem, actually kind of an iceberg phenomenon, is that attempts and completions represent just the tip of a much larger population, those who have serious thoughts of suicide, and these are the people that we may encounter routinely in clinical practice. When we add in the adolescent data, we're looking at 16 million Americans with serious thoughts of suicide. And we've been trying to change the conversation a bit around this, that we should be much more focused on people with serious thoughts of suicide. If we were better at identifying them upstream and treating them upstream, we'd have fewer go on to make attempts and fewer still to result in deaths. So I really want to focus on this kind of level of suffering. Suffering that's so exquisite that someone thinks about extinguishing their existence, which is a pretty profound thing to do. Now, if we take a look at history and we look at our field, in many ways, it's kind of shocking or horrifying how we thought of mental illness. I will impress upon you that each major world religion, Christianity, of course, Catholicism in particular, but others as well, Judaism and Shintoism and other Islam, all have versions of ritualistic um, uh, um, sort of getting rid of evil spirits. I'm searching for the word and I'm not retrieving it. Um, but different kinds of rituals to drive out evil spirits. Even an early form of waterboarding in the church history. And this idea of exorcism, thank you very much. Exorcism is a universal explanation for why people would act bizarrely or curious behavior. And maybe in a sort of a more societal sense, while we were trying to drive out evil spirits or the devil, we were also inclined to put these people out of sight and out of mind. In other words, they were aberrants, they were deviants, and in civil society in Western Europe, for example, we'd rather have them sort of locked up or imprisoned than to have to see them in our streets or deal with them on a daily basis. Um, Certainly not therapeutic. And when we think of the early therapies of that era, they were relatively primitive. I'm pretty convinced that bloodletting never really helped anybody and probably made people a lot sicker, but it was used for abnormal behavior. for the suicidal lunatic, for example. And trephination or drilling a hole in the cranium to let out evil spirits or take pressure off the brain certainly was never therapeutic, definitely left a mark. So this history, I think, is quite relevant right to the present day because it speaks to a desire to do something and to make somebody come to their senses. The Latin term is non compos mentis, which means not in one's right mind, which was synonymous to being a lunatic. If you were suicidal, that was evidence that you were not in your right mind. If you were to take your life, that would be an act against God or an act against the king, who's a proxy for God. And therefore, your family could be punished for your suicide attempt. You could be put to death for attempting suicide because of the transgression towards God and the king. So, interesting sort of ways of thinking about this early on. And then this gentleman comes along in the 18th century and says, I'm sorry, 19th century, and says, we really do, 18th century, I'm sorry, we really do need to have a different approach to the mentally ill. And this is Philippe Pinel, who was a doctor at El Salpeter, which is a large asylum outside of Paris. And famously, in these very glorious paintings, you see his ushering in the notion of moral treatment. Now, he's influenced by Rousseau and some of the other French philosophers to say we should not be, treating these people as animals. We should be liberating them, and we should be creating asylums. We should be creating sanctuaries where these people could be protected from all the ills of society because they're special and they deserve our protection. While it was a very compelling philosophical idea, the reality of asylum has often been associated with warehousing of people, people living out their natural lives in these institutions where they were assaulted and abused and not treated very well. Interventions mostly involve controlling violent behavior, different kinds of devices and different kinds of interventions to control violent behavior. Electrifying the entire body was a very early intervention before we got a little bit more focused with the temporal lobe electrocution or electroconvulsive therapy, which is now much more humane in the contemporary sense, and was for a long time the only thing that people knew to do to break psychosis or depressive states. There was surgeries, cingulotomies, and more infamously lobotomies. The ice pick lobotomy being demonstrated here by William Freeman is especially horrifying until you sort of like take a little bit of perspective on it. In the 40s and 50s, patients could not be controlled. Before Thorazine, violent patients could assault staff, they bite themselves, they would do horrible things. But then they could do these lobotomy procedures, and Dr. Freeman might do up to 15 a day, um, tapping in an ice pick instrument into the orbit of the eye and then swishing around the prefrontal cortex. And almost like magic, if the patients survived the procedure, they behaved very differently. So in its day, it was seen as a revolution, and William Freeman felt he should receive the Nobel Prize for this procedure, and did thousands of patients all the way up into the 60s and maybe early 70s. Um, of course, this is no longer done in the present context, but I say this all in the spirit of people did the best they could with what they knew, but some of these very primitive treatments could actually be quite damaging and quite irreparably harming. There were also institutions, and the Kirkbride plan was designed by an American doctor that really emphasized both light and air as the primary treatments for those who had severe mental illness. I'm a bit of an enthusiast about our history. And this particular building here, the Trans-Allegheny Lunatic Asylum in West Virginia, is an unbelievable example of the Kirkbride design, and one of their units has been restored to its original glory. And it does feel like a therapeutic environment. By the time it was shut down in the late 1970s, early 1980s, a building that was constructed for 300 patients had over 3,000 patients. So again, it was not therapeutic. It was a warehousing and probably mostly iatrogenic. If you're interested in this at all, I recommend this book, Desperate Remedies by Andrew Scull. It's just a fascinating walk through our history And why I think is so important is that it leaves with us this feeling like we have to make people not be crazy. And that requires an external intervention. Now, when it comes to suicide, we have one example in healthcare delivery where we can make somebody succumb to a treatment because they're not in their right mind. I'm not saying a hospitalization is never warranted. There are extreme examples of violence and people being homicidal and suicidal, but I am clearly saying that many people who are hospitalized because of suicidal thoughts could easily and readily and more effectively be treated on an outpatient basis. To me, it's akin of a cardiac or a person with heart disease having chest pains, and then the cardiologist having their chest cracked open to do exploratory surgery. That would be a way overreach from a clinical standpoint for someone who merely has chest pains. So too, if people have suicidal thoughts, why would we put them in the hospital for just a few days, which is our most expensive, most extreme, most invasive intervention, when there's much safer and much more effective ways to work on an outpatient basis for many, many people who are suicidal? Again, 16 million people. That's 300 times greater than the number of people that die by suicide. That's the population of Manhattan doubled. It's a lot of people. So I've been part of a task force here in Washington. When you live in proximity to Washington, you're on a lot of task forces over the years. I've been at this for 40 plus years. This is a very compelling task force supported by the National Action Alliance for Suicide Prevention. It was a simple set of recommendations, the low-hanging fruit of what we could do that has evidence that would not require tremendous training that you all can do as of today's webinar, which is to screen for suicidal risk, to manage the acute risk using safety planning and lethal means safety discussions, sharing the national crisis hotline and text line numbers, maybe treating the causes of ideation and behavior, which is something I feel very strongly about, and then following up and following through. I teach ethics in our PhD program. I think a lot. I'm married to a lawyer. My son's a lawyer. I think a lot about legal management of risk. Clinical follow through is crucial, and even carrying contacts after a patient is discharged. I've written papers for the National Register, on just sort of these common sense approaches, and I'm going to cover these in the course of today's discussion. The Joint Commissions, which accredits over 20,000 hospitals, embraced our task force report and made four strong recommendations for safety planning versus no harm contracts, a warm handoff to outpatient care, because we know the transition out of inpatient care to outpatient care is very high risk for completing suicide, carrying contacts and follow up at discharge, and then a discussion of lethal means safety and safety planning um, at the point of contact or discharge disposition. And this paper got published. It was a survey of, I think it was 8,000 respondees across the 20 plus thousand about how well they're meeting these national patient safety goals for suicide prevention. And you see pretty abominable findings. Safety planning is done 61% of the time. It's not done with adherence, so it's probably a really poor version of safety planning. Probably not collaborative, probably not the way Barbara Stanley and Greg Brown intended to be done. Warm handoffs 37% of the time. Carrying contacts or follow-up 30% of the time. Lethal means safety only 28% of the time, which is probably the single thing we can do the most to actually prevent suicides. Taken together, 8% of those responding, so they felt good enough to respond to the survey, are doing all four of these things with adherence. It's not an opinion. These are data about how badly Joint Commission accredited institutions, according to the survey, are doing with the low-hanging fruit of what any patient should get in an American accredited hospital. It's just horrible. So I am part of critiquing the status quo or the standard of care, trying to shape that standard of care. This is a paper that was published in Professional Psychology Research and Practice, where we said we've got a relative crisis, an ethical and competency crisis with regard to suicide risk. This was a follow-up paper in Practice Innovations, writing about CAMs. And I said, well, I got to take another whack at the field because most clinicians are not doing things that have been proven to be effective. And then with Jeff Barnett, I published a paper in American Psychologist that was shocking to me. We submitted this paper, honestly, to be candid, fully expecting a desk rejection because I've just been underwhelmed by institutional psychology's receptivity to evidence-based practices and a suicide-focused care. It's kind of like if you can just lock people up, throw away the key. That's what we want to do. Not only was this paper not desk rejected, it was one of the best reviews I've ever gotten. And it really just spoke to we have a 30 plus year evidence base for assessing and treating suicidal risk. We should be doing that. We want to be ethical psychologists and we want to decrease suffering. Of course, we want to save lives. So this paper to me was, at least in my publication history, a bit of a watershed that maybe there's a receptivity to these ideas. We have 500 plus people on this webinar. That's great news because 5 years ago, a talk like this would not gather that many people. Okay, so a little bit of soapboxing, sorry, but that's just my take on things. Um, what I'm happy to say is that we do have policy initiatives, one called Zero Suicide, in which I've been involved since its inception. That is a policy and systems approach to care that's meant to raise the level and standard of care for suicide-specific care. Um, I don't love the name, but I've become sanguine because it's actually been a game changer. The most successful policy initiative that's now used broadly around the world. My recommendation for the task force was best possible care. And everybody's like, it's not really very compelling. Zero suicide, though. What number would ever be acceptable? My problem with zero suicide is that it creates an expectation that if there is a death, that there's been a failure by the provider or a failure in the system, when they may have done superb evidence-based care, and that we can reliably offer. So we just made best possible care the motto for our training company, and it didn't make the name for zero suicide. And I get it. I mean, if this gets people's attention and starts to change the standard of care, then why not go with it? Zero suicide is made up of seven elements: to lead, train, identify, engage, treat, actually treat what makes people suicidal. And that tends to be the flyover state of the model. People tend not to kind of skip the treat step. So I'll definitely be talking about that today. Transition, care transition is big, and then to improve practices and improve the standard. So there is a psychologist at the Gold Coast in Brisbane, Australia, who instituted zero suicide at her medical center and has been a spectacular success in that large healthcare system. You could use zero suicide for your small clinical practice. You could use this in a community mental health agency. So zero suicide has a flexibility and adaptability, which has made it in some ways more compelling than other similar policy initiatives. So if you're not familiar, check it out. American taxpayer paid for it. Here's the website, and they have free resources for you to develop a zero suicide initiative in your clinical location or system of care. Another great innovation that we've seen in the course of my career have been really breakthroughs in modeling and theories and conceptualizations of suicide. I'm not going to go deeply into these, but to say that Ed Schneidman kind of got the ball rolling back in the 80s with a cubic model where he looked at the convergence of psychological pain, which he called psychache, the impingement of stressors. We're in a heat dome right now here in DC, and I'm not going to kill myself over it, but the weather or severe weather can actually create a lot of stress in somebody's life. And then perturbation or dysregulation. Think of loss of frontal control, activation of the limbic system. And Ed argued that where these combine is where people are in imminent danger. So it's a nice convergence or synergy model or perfect storm type of model. And it also gives us guidance as to where we intervene. We can intervene with pain. We can try to decrease stressors. We can medicate or teach somebody to mentalize or do mindfulness-based psychotherapy to decrease highly dysregulated states and states of agitation. Thomas Joyner has a similar convergence model that emphasizes relationships, that those who are suicidal often perceive that they're a burden on their loved ones and that they'd be better off without them, and that they want to be attached to people who reject them. So, for example, in the military, where you work in a unit, you could be perceived as a burden to your unit and not really attached with your battle buddy. And that creates a interpersonal sort of suicidal level of distress. And then he has this notion of acquired capability that we are biologically wired to not want to die, but through combat, exposure, trauma, multiple attempts, we may gravitate or evolve to actually being capable or desiring to die. And where these intersect is where attempts or deaths occur by suicide, according to Thomas's model. So simple models, three major variables. Rory O'Connor at the University of Glasgow in Scotland has a more complex model, the integrated motivational model, the IMV model. He's looking at how do people end up in the suicidal behavior bubble here. It's a combination of biology, environment, and life events that move someone from defeat and humiliation through a feeling of entrapment to ideation to behavior with different kinds of moderators. And Rory's able to look at all the different moderating impacts of this sequence. David Klonsky, Alexa May are two psychologists who developed the ideation to action model, how some people remain in the ideation lane, whereas some people get triggered and go into attempt behavior. David Rudd, Craig Bryan developed the fluid vulnerability theory that talks about warning signs in the suicidal mode, which I'll talk about more later when we talk about treatment, and that there are acute and chronic states, and people can have chronic states that also have an acuity connected to them. So this is just meant to say the theoretical conceptual world in clinical suicidology is alive and well. Lots of very thoughtful people. This is driving both practice and innovations in practice, and it's driving our research as well. A big pursuit in the field for over 100 years has been the idea of a typology. On the left here, you have Emile Durkheim, who was a sociologist in France, wrote a very famous book called Les Suicides, published in the late 19th century, organized people who were suicidal as a function of their social integration or lack thereof. So people that were overly socially integrated to a radical idea or the notion that you should go into a crowded market and blow yourself up, that'd be an example of altruistic suicide. That your belief that killing a bunch of people in this manner and losing your own life in the process is for this greater spiritual or political good. So Durkheim got us rolling, and then there have been many, many efforts to typologize, some using multivariate analysis, factor analysis and the like, more recently latent profile analysis, but different ways of kind of organizing acute versus chronic states. Ecological momentary assessment is using a smartphone basically to get multiple pings. And Evan Kleinman and Matt Nock have identified and replicated 6 different types of ways that people ideate. So each color represents a different kind of ideation as they have multiple time points and data collection. And then with regard to a diagnosis, because you can't get reimbursed for treating someone who's suicidal without giving somebody a major affective disorder or adjustment disorder, there is a hot pursuit developed by Igor Galenker and Thomas Joyner to develop a DSM-6 diagnosis. It looks like the suicide crisis syndrome is going to win out as a DSM candidate. I've been involved a little bit with the acute suicidal affective disturbance. They're very similar, describing of a very sort of acute, imminent state of risk that could be a reliable diagnosis. So it's the fruition of the pursuit of typologies because people are different, and you don't treat everybody all the world's not you don't treat the world. You don't have a hammer, all the world's a nail. You have different tools for different kinds of needs. This is some controversial thing, and people in my field love to be controversial. That screening may be problematic. I'm not of that mind because there's a subset of people that will acknowledge being suicidal upon screening, which I think is really helpful. Some will deny, and some will say they're suicidal when they're really not, and who are suicidal will say that they are. It's an issue of validity, but a subset of people will acknowledge when asked on the PHQ-9 on the Columbia Suicide Severity Rating Scale, or the ASQ. Do you have thoughts that you'd be better off dead or hurting yourself? That's the PHQ question number 9, which we've shown actually misses too many people are suicidal. So published in Psychosomatics showed that just misses too many people. Certainly better than nothing. But the PHQ-9 is a depression screener and should not be used as a suicide screener. Much better options, in my view, and I'm on the Ask team, is the ASQ, which is basically 4 to 5 questions. Originally developed with adolescents and pediatric populations. It's now been normed for adults and military populations as well, and the Columbia. The reason that these are the 3 most popular screeners is that they're free and they're online. And so that drives clinician behavior. And a Columbia or an Ask in your chart is going to decrease your liability because your clinical judgment is now being supplemented by a valid and reliable screening tool. What people go crazy about in my field, like it's a whole new thing, but it's not, it's like decades old, is that we can't predict future behavior. I learned about this in the 1980s, that we can't predict future behavior. But that doesn't mean we throw the baby out with the bathwater. It means that we can have concerns that are warranted because somebody's saying, I'm suicidal. And then how we sort of make sense of that or conceptualize that is sort of the key as to how we proceed in the assessment process. This is Professor Paul Meehl, who for decades did research on actuarial assessments, and this is just a short list of hundreds of measures developed in the field, carefully psychometrically constructed with their own psychometric validity and reliability data. None of these predict future behaviors. Nothing does. We're not soothsayers, but we don't have to be. We just have to be able to talk about relative risk. And these scales are actually quite good at talking about relative risk. But Professor Meehl did a series of really interesting studies looking at clinical intuition and gut judgment, and showed in study after study after study that actuarial assessments always beat clinician gut judgment. The exceptions, of course, are us on this in this webinar because we know that our clinical judgment is superb. We all went to law school to develop that judgment. My argument would be you can supplement your clinical judgment by using even one of the online available tools, and more input in your medical record is going to be protected from liability. Plus, we have now really cool linear analyses and latent profile analysis and machine learning, which is either vilified or it's the second coming. You know, it's a tool that can be used that helps in our predictive modeling. I'm sort of a cake and eat it too kind of person. I've seen machine learning be value added, but it's not the be all and end all. That said, any assessment tool that supplements your clinical judgment is going to decrease your liability and certainly be in the patient's best interest. Now, if we do rely on interviews, which most clinicians do, we know because we did a survey, and that's what clinicians do. There was a group in Ashi, Switzerland, that met for 6 meetings, and then we published a book on how do you talk to a person that's suicidal, because the dynamic is problematic in its nature. Have you thought about suicide? Well, yes, I have. Well, you can't kill yourself. Well, who the hell are you? It's my life. I can do what I want to do. No, you can't. Yes, I can. You want to bet? I do. I'll call the police. Nothing about that dynamic is therapeutic, to say the least. We want to engage and talk about this in a very different way. So this book that's now out of print, unfortunately, really talked about, and at these 10 different conferences, talked about how we engage with this topic differently so that we're not in an adversarial relationship with the patient, but we're engaged with the patient, listening to their narrative and benefiting from that narrative description of their struggle. Here's our friend back on the bridge in the Golden Gate. Now, one of the things I'll say that's really striking about this picture is that this person now doesn't die because a netting system has been erected along the span of the Golden Gate where he would be captured and then shuttled off to the terminus of the bridge. So that's called lethal means safety. We're going to get into that here in a minute. But one of the things about ambivalence, which I think this picture speaks to, is that we know from research that David Rudd has done, Craig Bryant, myself, is that we can look at ambivalence using Aaron Beck and Ria Kovac's scale for suicide ideation and looking at the wish to live versus the wish to die. And David has a data set right now where he's seen people who get into a space where they are all about dying. They have no wish to live. And he refers to these as resolved wish to die. There's a kind of cognitive dissonance that kicks in that this is what I'm gonna do. I don't want to be talked out of it. And in that spirit, that's a hard mindset to change. And yet they're with us and they're still alive. So I was just at a conference in Vienna, Austria last week, and we talked a lot, David and I did, about how do we create ambivalence where there seemingly is none? How do we get a foot in the door to kind of create a little bit of wiggle room? And I'll speak to you a little bit more about that as we go, because ambivalence is on the side of therapeutic outcome. Ambivalence is the salvation for many patients that we might otherwise see, even ones who are in the seemingly resolved wish to die category. So we talked a little about history, a little bit about models and theories, a little bit about screening, a little bit about assessment. Let's talk about intervention around acute states. This is what our laws in different states across jurisdictions requires of us, that we are mindful of clear and imminent danger. The problem with clear and imminent danger is that nobody knows what it means. Lawyers don't know, judges don't know, psychologists don't know, mental health people don't know. It's not operationalized anywhere. I had a master's student who's also getting a law degree do for her topic paper a review on clear and imminent danger. Clear and imminent danger range from 1 hour up to 6 months, with about 52 different operational definitions. Essentially, what we are looking for are people probably in the next 24 hours who, in our judgment, might be in a place to do self-harm behavior. Um, Now, a lot of us were raised in a model where we had somebody promise they wouldn't hurt themselves, they wouldn't act on that feeling. Those are called no harm contracts or no suicide contracts. If you're using that or having people commit to their safety, stop it and do this instead. Have people do a safety planning type intervention, either the Stanley Brown safety plan, which is here on the left, or the crisis response plan. The crisis response plan actually has a little bit better data, but they're very similar. Each identifies warning signs, different things to do to cope, different resources. The safety plan does talk about lethal means safety. The crisis response plan is done in the patient's own hand, writing on an index card, which they would laminate and have you put in your pocket. Turns out from the neuroscience of this that writing is different than typing. We encode differently, we remember differently, retrieve differently when we write things out. So it personalizes a very similar kind of first cousin type intervention. In CAMS, we have something called the CAM stabilization plan. We start with lethal means safety, talk about different ways of coping, different resources, ways of decreasing your isolation and coming to treatment. These are all first cousins of the same basic idea. Instead of promising what you won't do should you become suicidal, let's figure out what you will do or try to do if you become highly dysregulated and feeling like doing self-harm. And so to that end, we really are keen on these interventions. They all have evidence. The one with the best evidence is crisis response planning. There's a large case control VA study of safety planning that's pretty persuasive. Other clinical trials are ongoing. CAM's stabilization plan exists within a treatment, so we don't really study it in separation, but certainly part of an effective treatment that I'll talk to you about later. Meta-analysis coming out of Europe a few years ago showed 6 different safety plan type interventions and showed a signal for decreasing attempt behaviors compared to control care, but not a significant effect for ideation. And this represents a bifurcation of some of what we see in the treatments for suicide risk. There are treatments I'll describe to you that are very good for reducing attempt behaviors, but not necessarily ideation. There are others that reduce ideation, but not necessarily attempt behaviors or self-harm. So that is something we have to track and be thinking about differentially when we're talking about different kinds of treatment plans. Similarly, beyond safety planning, we also want to think about lethal means safety. We want to think about 988 Suicide and Crisis Lifeline, the National Text Line, and different things that we can do. for somebody who's in immense distress. At a minimum, and this is part of the national safety patient goals that I described earlier, we should always be recommending the National Lifeline 988 and the National Text Line. Text home to 741-741. You might want to consider, I do in my own practice, giving somebody your smartphone or your cell phone number or not, or if you have a cover phone or coverage protocol or something like that. But really, ideally, the patient can reach a provider if at all possible, but we can talk about that. Um, Otherwise, giving the Lifeline is perfectly respectable. My wife, who's an attorney, worked on the Lifeline for several years. A lot of her callers are people who had therapists who didn't want to take after-hour phone calls, so they called the Lifeline instead. Or if they did talk to their therapist about being suicidal, they'd immediately get hospitalized when they didn't need to be hospitalized. So she took a lot of suicidal calls from people who had providers, which seems problematic to me. Lethal means safety is probably the single best thing you can do. The counseling on access to lethal means or calm is a free online training to decrease lethal means. I think about this all the time because we do randomized controlled trials, and I've had patients over the years who have stashes of pills. We had a clinical trial with the Army in Fort Georgia and Fort Stewart in Georgia, and a soldier who had a stash of pills, where the clinician interrupted the session because he was so concerned about her that she brought in her pills. It was a lot of pills. So when we intervene in this way and literally remove a firearm or a stash of pills, we have now made this person much safer. I was just on Capitol Hill this week for the AFSP, American Foundation for Suicide Prevention Forum. One of our asks is a new bill that would provide storage devices for veterans, whether in VA or out of VA, to store their firearm handguns for free. It's a bipartisan bill, which is really tricky these days, that we think could actually get passed. It's probably the single biggest thing we could do to decrease veteran suicide. The vast, vast majority of vets that kill themselves shoot themselves with firearms. So the goal here is to secure these lethal means and to get verification to that effect. So now we're approaching treatment. And I want to say a little bit about the evidence base because you can't swing a cat without figuring out, without hearing something's evidence based. And what I would sort of say with a little bit of critical review is that gatekeeper training like QPR Assist, SOS are really fantastic, but we don't know in training people who might interact with people that are suicidal if it actually impacts people who are in fact suicidal. So that's a big internal validity issue. So I'm not dissing these interventions, and it's good for people to be more equipped to talk to people that are suicidal, but we don't yet know whether it has actually an impact on people that are suicidal in decreasing their suffering, their ideation, or their behaviors. Screening, as I talked about, has very psychometric virtues, and the prediction issue plagues the field. People get very activated about this. I would still recommend the ASQ or the Columbia as a screener. It's not perfect, but it certainly identifies a subset of people. I talked to you about assessment tools and how people prefer clinical judgment, which could be supplemented by assessment tool. Interventions like safety plan type interventions, lethal means safety, digital interventions, carrying contacts are not treatments. They're meant to stabilize somebody, but they don't really fix somebody necessarily in terms of suicidal risk. There are treatments I'm about to describe to you that actually reduce ideation and behaviors. And these treatments have varying degrees of support. So what I'm going to be really promoting are randomized controlled trials, which are experiments that get into causality with replication and independent replication, which means the developer of the intervention, other people have seen the same effects in a randomized controlled trial to get us to that top level of empirical validation. Okay, having said that, here's what we know. The vast majority of interventions that are effective for suicide risk are psychological, by far. You could argue IV ketamine is helpful for a very brief window for about half the sample. SSRI data is very mixed. Clozapine has one randomized control trial, and the FDA approved it as a suicide preventive agent for schizotypal, schizophrenic suicidal risk. My intervention has 7 randomized control trials, and you probably never heard of it. So It's just a bias that we have towards medication, somatic treatments versus the psychological treatments, which actually are effective and proven to be effective. So give or take, there's maybe 150 RCTs, but those RCTs that just focus on ideation and behavior, there's no support for inpatient care. There's a new study on behavioral treatment, a cognitive behavioral treatment that does show an impact for inpatient care, but it's a suicide-specific intervention for inpatients. But inpatient hospitalization, as I showed you, is abysmal, according to the Joint Commission's data, and we really need to have more specific suicide-focused care. And we know for sure there's increased risk post-discharge from hospital stays, and that's been replicated around the world. There's a handful of treatments like OSIP and mentalization-based therapy that have been either had a single RCT or RCTs that have only been within their group. And we're looking for that independent RCT to really say this holds up. And that's a fairly short list. Dialectical behavior therapy, or DBT, is king of the hill. Two forms of cognitive behavioral therapy that are suicide-focused, and CAMS, which is the one that has been developed by my lab. So my argument with Sam Chalker is that one size doesn't fit all. We need different interventions for different needs, and that's what's in the patient's best interest. So this is Dr. Linehan. Marcia is now retired and certainly one of the sort of the trailblazers of our field. There's over 24 RCTs that support dialectical behavior therapy for a whole range of conditions, not just borderline personality disorder. A very famous study that Marcia did here looked at treatment by experts. So Marcia is big on efficacy trials. She was the developer of chain analysis that behaviors don't happen out of the blue. There are certain feelings and cognitions that kind of lead up to that moment and different opportunities for intervention. This is a way to mentalize how you get in trouble behaviorally. It's a very useful tool among a range of things that they do in DBT. There are four modalities. Group skills training is the sort of like the secret sauce that's further crafted individual psychotherapy, and then also practiced in out-of-session phone coaching sessions. And of course, because these populations are so challenging, Marcia built into the model team consultation to support each other working with very high-risk patients. This is the data from that really elegant efficacy trial showing a significant reduction in attempt behaviors and in self-harm at 24 months follow-up compared to expert care in the Seattle community. Here's the late Dr. Tim Beck. Tim died several summers ago at the ripe old age of 100. Major innovator in obviously cognitive therapy, but also a major suicidologist, recipient of the Dublin Award from AAS many years ago. And my protege, Greg Brown, who worked with Dr. Beck for many years. They published a paper in 2005 that was a landmark paper for cognitive therapy for suicide prevention, or CTSP, and the development of a relapse prevention protocol, Hope Kit, which I'll talk to you about here in a second. They took a sample of patients who had made attempts in the Philadelphia community and randomized them to two conditions, one receiving 10 sessions of the CTSP intervention, the other receiving usual care. And they showed that this suicidal mode model that Dr. Beck developed and this relapse prevention protocol using the Hope Box was highly effective in reducing attempt behaviors by 50%. Interestingly, did not move the needle on suicidal ideation. And so we're mindful of that decreasing behavior is important. And this paper published in JAMA was a landmark study. And a 50% reduction is huge. The relapse prevention protocol was really something to look at your last attempt in a guided imagery exercise in session 9, right after the moment of the attempt, and then taking out your Hope Box and looking at each item in the Hope Box. This is a memory aid to remind you, it's covert sensitization of why you should want to kill yourself. And then session 10 would be, imagine a year from now, the suicidal mode being activated and using your Hope Kit and the skills that you learned in this 10-session CTSP intervention. So great data for reducing attempt behaviors. David Wright at the University of Memphis, Craig Bryan, who's at Ohio State, did a replication study, about 90% similar, called BCBT. This has been further replicated in an inpatient study that was done just this last year. a four-session version of a BCBT focused on suicide risk and attempters, 60% reduction in a Fort Carson sample with mostly male soldiers who have been heavily deployed to Iraq and Afghanistan. So great replication, independent replication, and now yet another inpatient replication. I believe there's yet another RCT I just heard about last week in Vienna. So really good data. And David really took Tim's idea of the suicidal mode and fleshed it out much further. The predispositions on my whiteboard in my office will be the things that are unique to your history. We'll identify your triggers that you know get you in a horrible state that then activate what Dr. Beck and then later Dr. Rudd referred to as the suicidal mode. Certain specific cognitions that you have, changes in your physiological and brain chemistry, probably certainly defeating behaviors that make things worse, and then very intense emotions. And these elements are highly interactive when you're in the mode. So a lot of what these interventions involve is recognizing that I'm headed for this mode. And you're probably highly dysregulated. How do we re-engage the prefrontal cortex, either through the relapse prevention protocol or your safety plan or your hope kit to get you down regulated so you're in a better place and not being sucked into the mode. 60% reduction in attempt behaviors. And this has been now converted to an app called Aviva under FDA review. I think its approval is pending. This could be a supplement to clinical work or actually self-administered when the FDA finally approves. It's quite the process, I have to tell you. Mentalization-based therapy by Bateman and Fonagy, very popular in Europe, where I just was. Really nice data, very much like DBT data, but not independently replicated. So we're looking for that independent replication of mentalization-based therapy. Attachment-based family therapy developed by Guy Diamond is a really elegant family therapy-based intervention that reliably reduces ideation, but doesn't touch steps. So we got, again, this dialectic between attempts and behavior, between attempts and ideation. There are a number of RCTs, I believe, last I talked to Guy, to replicate that would be independent replication. Right now, it really needs that independent replication to get full empirical validation. Then there's CAMS. So I'm going to talk a bit about CAMS. It's a metaphor for, I think, what effective care should look like. CAMS is my remedy for my own anxiety about working with suicidal risk, developed over 30 years. I first presented the model in 2000, so it's been about 25 years in the public domain. This is the third edition of the Guilford Press book. It's sold about 65, 70,000 copies. So there's a fair amount of interest in CAMS over the years. It's a framework and not a new psychotherapy. The pillars of CAMS are empathy, collaboration, honesty, and being focused on suicide. And we take a side-by-side seating with the patient's permission to really validate the patient's experience in a very particular assessment and to identify what the patient says are the things that make them consider suicide, which we call drivers in CAMS. So the intervention is guided by this multi-purpose assessment treatment planning tool called the Suicide Status Form. I'm not expecting you to read or understand this. I will say that the first page is completed in the patient's hand in this collaborative seating arrangement, different quantitative and qualitative responses. There are risk and warning signs that the clinician reviews to the patient to develop a treatment plan to keep somebody out of the hospital, if at all possible. But to do that, our first problem is your self-harm potential, and here comes our stabilization plan. So discussions about lethal means, different coping strategies, different resources to reach out to, ways of decreasing your isolation, ways to actually make it to your therapy. And then what are the two problems that make you consider suicide? In this patient's case, self-harm and interpersonal betrayal, for which we have many interventions. In-center psychotherapy, behavior activation, cognitive therapy, couples therapy, group therapy, medication, whatever works to treat a driver is what is done in CAMS. So these documents are completed with the patient, and the patient gets a copy of their SSF. This is an additional page of documentation that's conducted after the session about mental status, a diagnosis, relative stability in the case notes. There's a different version of the SSF for interim care. So that's all the care that occurs after the first session. and a final outcome disposition of the SSF when criteria are met for outcome disposition and resolution of CAMs. It's a very different kind of engagement. The patient is the expert of their own experience. The clinician's challenge is to follow them and to treat the drivers the patient says makes them consider suicide. COVID comes along, you can't sit next to your patient. You've got to move to a platform. This is a fillable PDF of the SSF. If you get the Guilford book, you can get access to the fillable PDF of CAMS. Here I'm meeting with a patient and filling this out for him. Patients always get a copy of their SSF. First session, all interim sessions, and their outcome disposition session. We've negotiated with Guilford Press to get the SSF into all the big EMRs, and they are now installed or being installed in the big EMRs. So the SSF lives there. If you work in one of these settings that uses these major EMRs, you can pull it down and use it within your practice. So the model I grew up in, suicide is a symptom of depression. Clinicians in a superior knowledge position. This person's on their way to the hospital. We'll treat the depression to get rid of the suicide, and I'll have them sign my no harm contract. This is a bankrupt model. It's still widely used. It's a very unfortunate dynamic because it makes the clinician the expert and the patient passive, a recipient of our care. The CAMS model really switches this up in this collaborative dynamic. I'm an old Rorschacher, so that was probably a little bit of the inspiration of the side-by-side seating arrangement to look at suicide through the eyes of the patient. We do that through the SSF. So it's a mentalization activity where the patient's looking at themselves from the outside, the clinician's looking at the patient from the inside as to what makes them suicidal. Many patients will tell us, because I'm depressed. As a CAMS clinician, we'll say, well, what are you depressed about? They're depressed because they hate their job. They're depressed because their relationship is blowing up. They're depressed because they hate themselves. And so when they say they're depressed or anxious, we ask them, what are you depressed and anxious about? Because those are things that we can treat, those drivers. Because for us, how the patient construes this, the phenomenology of their suicidal struggle, is what we target and treat in this framework. Very different dynamic, very clear, strong alliance is meant to sort of form around the issue of suicide. So adherence to the model requires a level of sort of buying the philosophy. We're empathic. We don't shame. We don't blame. We don't wag our fingers. We are empathic. We're collaborative. We're honest and transparent. I present the DC Mental Health Act or the Maryland Mental Health Act, depending on where I'm practicing, about the nature of clear and imminent danger and how I don't want to ever go there. I probably hospitalized somebody last about 20 years ago. Now I've got a very high tolerance level, and I do see people who are suicidal, but I think the vast majority of people who are suicidal can be safely treated on an outpatient basis. Exception might be acute psychosis or where there's a homicidal suicidal risk, but the vast majority, I believe, can be effectively treated on an outpatient basis. So there's a philosophy that we want people to embrace. We also have this framework that focuses on suicide. It's oriented to keep somebody out of the hospital. And that's flexible. You can be a cognitive therapist in Denmark that are psychodynamic, in China that are remarkably Freudian. All of those can work within the CAMS framework. We watch videos in my lab of clinicians using CAMS. This is the CAMS rating scale, and we give people feedback as to how adherent they are to this basic model. Are you collaborative in your assessment? Are you collaborative in your treatment planning? Do you understand in this collaborative way what the patient's suicidal drivers are? Have you helped flesh that out? Teenager says, everything in my life sucks. Well, we can't treat everything or your sucky life. Out of your everything life sucks struggle, what bubbles to the surface? The kid's bullying me online. Okay, we can intervene with that. So that's what we're looking for in interventions that then treat those drivers. And what we see is that when we make a little bit of therapeutic process, then we can bring in reasons for living. Then we can focus on plans, goals, and hope for the future. What Marshall Linehan talked about back in the day, a life worth living. So this is the first session SSF. The first 3 pages are completed with the patient. This page is completed after the session. This all is part of the medical record. It absolutely meets the requirements under HIPAA, the privacy rule, for this to function as the medical record. Treating drivers, whatever interventions that you know to treat direct drivers, that's what's on the treatment plan. But we also look at indirect drivers. That might be your diagnosis. That might be the voices. That might be your substance abuse. You don't want to kill yourself because you're drinking. But when you drink a lot, that's when your direct drivers kick in. So we give the patient, like the other interventions, a working model of who, what, when, where, and how do you get in trouble. And then when you get in trouble, what do? You go to your stabilization plan. You call your best friend. You call the National Lifeline. Treating drivers, you can do whatever makes sense to you to treat those drivers. This paper was published a couple years ago looking at drivers. By far, the number one driver that we see from two clinical trials that were funded by the DoD and NIMH are relational issues, misery, and then what I do, and then issues of the self. So we've seen over the years that work and love really play heavy in the ideation of people that are considering suicide. Freud was at least right about that. This is a version of this is the interim session of the SSF. This is the update of the core assessment, which we studied in 3 different psychometric studies. It's valid and reliable. We're looking at the overall risk to come down to a 1 or 2, and that they're managing the thoughts and feelings for 3 consecutive weeks. So this is the version of the SSF that's used repeatedly to then update this treatment plan at the end of each session. Because these treatments evolve. Some interventions work, some don't. The drivers evolve. And then we have our additional documentation. We're looking for 3 consecutive sessions where the overall risk is a 1 or a 2, and they're managing the thoughts and feelings, and they're behaviorally stable for 1, 2, 3 sessions. And when that happens, there's a final outcome disposition, final check of the core assessment, a final outcome disposition, and a final level of documentation. And CAMS is done. So that's the model, very quick. The integrated training model can be learned about or gained from CAMS Care. It's described in the Guilford Press book if you're interested in that. But tons of data. I'm not going to belabor the data. I want to make sure we have time for questions and answers. But really, lots of robust evidence in 11 correlational and open trials. CAMS reliably works. It drops ideation like a rock. It drops overall symptom distress. It reduces hopelessness. It reduces depression. But really, it's the RCTs that have been the major focus. This is our first RCT where we showed a big drop in ideation compared to treatment as usual, increased reasons for living, decreased overall symptom distress, increase in hope. Here's a meta-analysis of 9 CAMS trials showing how CAMS reliably reduces ideation, overall symptom distress. The single biggest effect was increasing hope and decreasing hopelessness, and treatment acceptability and adherence to care. And other related markers are all trending in these forest plots, and it's only 9 trials. So the data is pretty supportive in terms of what we know works with CAMS. This is an inpatient trial where we got a clear signal at 1 month post-discharge, which is a very high-risk period for decreasing attempt behavior. So that's really good news. We want to replicate this, of course. So this is an inpatient version of CAMS against actually a pretty good comparison treatment, where we had a reduction in ideation, better alliance than the control treatment, significant reduction in attempt behaviors at 1 month. So looking to replicate. So these are the RCTs. This is the German trial I just described to you. We clearly know that CAMS reduces suicidal ideation and symptom distress and has its biggest impact on hopelessness. And there are 5 ongoing trials, a VA trial in San Diego, a campus trial, 4 universities across the country, and that data is now being analyzed, a SMART design looking at CAMS and treatment as usual, and then a second randomization to CAMS or DBT skills group. A trial for teens, 2 trials for teens funded by NIMH, one a ketamine trial versus saline with CAMS on the back end. Another trial with Barbara Stanley and Greg Brown looking in Jeff Bridge and Molly Adrian looking at adolescents at Seattle Children's Hospital and Nationwide Hospital in Columbus, Georgia. And then a new trial, I just got a call about this, a PCORI trial looking at IV ketamine versus ECT with all patients at the back end of the trial getting CAMS. 1 session prior to discharge from inpatient care, 7 sessions post-discharge via telehealth. Cancer teens is super hot. Our biggest challenge are the parents. So in our clinical trial, we developed something called the Stabilization Support Plan. This is in the third edition, and it works really quite well. I can say, just having watched its use in the clinical trials, it gives parents a very clear role of lethality safety, the first page here, and after the session with the child, things that they can do to support the treatment differently and better. So it gives parents a very clear role. This stabilization support plan is parallel to the child's stabilization plan that they develop in CAMS. This is a really cool intervention, a one-session use of CAMS on empath units. This is a presentation I did several weeks ago in Dallas. Empath units are an alternative to inpatient care. It's based on a study that was done in Louisiana at LSU by Ray Tucker and Nick Oakey-Frost, where a single session, the first session of CAMS, demonstrated a significant reduction in subjective units of distress and a significant increase in motivation to live. One session, 100% delivered by graduate students in chaotic EDs and primary care and inpatient psychiatry. One session, increased documentation, and patients like it. We are now replicating this in several locations. Empath units are really cool. It's an alternative to chaotic ED experiences. The combination of empath and CAMS-BI is really compelling. So, if you have an empath unit or looking for an alternative, the vast majority of people that come to emergency departments are suicidal, 77%. The referral to empath unit may be the first step to an alternative experience. If you're interested in empath, just Google Scott Zeller or empath units, and you'll hear all about it. But this hand in glove kind of idea of a different kind of environment where you get actually a meaningful suicide focused intervention instead of only medication, which is more typical, is a pretty compelling argument to combine CAMS with this empath model. CAMS is used broadly around the world. There's not a lot of competition. We've seen a big uptake, and there are clinical trials going on in China. There's a new trial starting up in Australia, and probably a new one in Denmark. A lot of interest. The book we're just got now a Spanish translation of the book of the third edition, and many other translations as well. So I want to sort of start bringing this together and talk about a U.S. Army soldier who was really worrisome, had been extensively deployed and had lost many friends in combat. His two drivers were PTSD-related combat experiences and losing his daughters in a post-deployment divorce. Tom was seen for 16 sessions, and the thing that I remember about him is in session 8, where he talked about, moving down a road where all he could see was suicide. There was no off-ramp. There was no other place to go. He's in the Humvee. That's where he's going. And then in session 8, they kind of passed suicide, and now it's in his rearview mirror, and they're moving away from suicide, and now he's looking for an off-ramp. That's kind of how CAMS works. It's not a light switch. It's a rheostat that changes the patient's relationship to suicide and helps them manage the thoughts and feelings and ultimately pursue a life worth living on the back end. So just a quick case example of kind of what that looks like and how it sounds. This is a thesis from Trinity College in Dublin, Ireland. Clinicians' experience of engaging patients in the suicidal self through the CAMS relational experience of trust, openness, and acceptance, a resolution or a relief from distress, new learning, taking control, and the emergence of a new self. Just like it as a model of thinking about a different way to work with suicidal risk. Hope Institute, developed by Derek Lee, this guy here. All they do is CAMS and DBT Skills Group, developed at Perrysburg, Ohio. It's been now replicated in several locations. A new Hope Institute is being built out in Oregon. Highly effective in 5 to 6 weeks of keeping people out of the hospital and significantly reduced suicidal risk using only CAMS and DBT. So from an ethical standpoint and a liability standpoint, a lot of clinician behavior is driven by the fear of malpractice liability, which is tort litigation for really significant failures, a failure to assess, a failure to treat, a dropping of the ball. So from an ethical standpoint, your informed consent, use of clinical consultation documentation is all crucial across clinical care, but especially for high-risk suicidal cases. The standard of care is operationally defined each case by experts like me and my friends saying that this is the standard of care. And did the plaintiff, the defense, or did the defending clinician meet the standard? Did they successfully foresee? Did they treat? And did they follow through and not drop the ball? Obviously, if you do CAMS, it's baked into the model. You are assessing like crazy every session. You are treating suicide in a specific way with 7 randomized controlled trials and 11 open trials and 2 meta-analyses supporting what you're doing. The documentation is exhaustive and thorough, and you follow the case until they meet criteria of resolution. It's a metaphor, but it's also a literal way of ensuring a very low risk profile with working with high risk patients. It's a case of Sheila. I've written about this in Gary Kuchar's book on ethics, a series of case examples of experts in very challenging cases. One of the most challenging in my career, to be honest. I saw her for 7 years, mostly 2 to 3 times a week, profoundly sexually abused by a teacher in her high school, made 4 different suicide attempts and a near fatal fall from her 11-story balcony. I literally had my wife, Colleen, call her boyfriend, who raced to the apartment, who grabbed her as she was going off the balcony of her 11-story apartment. She regressed over 5 years of intensive treatment, and she was ultimately put on psychiatric disability as a nurse, hospitalized several times, and ultimately diagnosed with multiple personality disorder, including 12 different alters. That was kind of crazy. And my supervisor at the time suggested that maybe I want to rethink what I'm doing because obviously my treatment wasn't working. She was only getting worse. He was very kind, very gentle, but he was right. And so much against my psychodynamic training, and with the advice of George Bonanno, who's now at Columbia, I engaged in therapeutic repression to really push down the trauma, and she resolved very quickly. She's now 25 years sober, happily married, and an award-winning physical therapist out west. So it's not for everybody, but for her, repression actually worked. And we arrested a sort of free fall into a treatment that was dissolving and where she just got worse and worse to receive consultation, to reformulate the treatment plan, to go against what I knew to be the way to treat, to get a better outcome. And she has done quite well over the years. This is a problem. People that are suicidal don't want us. In fact, in this particular study, mental health systems came in number 4 to spirituality, talking to someone, or a companion, and positive thinking. They don't want us because of what they typically get when they go to the ED or to a hospital setting. We now do research with people who have experience, and they are telling us in exquisite detail how unhappy they are with the treatments that we provide, how the clinician, especially there's a new scoping analysis about commitment against people's will. It's helpful for medication, terrible for suicide risk. The data looks really, really bad for its impact on suicidal risk. It's a lot about autonomy. It's a lot about decision making. There are exceptions, of course, but we way overuse hospitalization medication to treat suicide risk when neither of those really has evidence in support of their effectiveness. Or if the evidence is there, it's very mixed or limited. Bottom line, the limbic system is our friend when we are in a fight or flight mode. The amygdala gets activated, and this part of the brain gets activated, and then this part of the brain turns off. The prefrontal cortex, the dorsal medial prefrontal cortex, all the part of the brain that's really critical where our mirror neurons live. As psychotherapists and as patients, what we want to be activated to be able to downregulate a dysregulated brain is what the good psychotherapy treatments that are suicide focused actually do. And if we are treating with confidence and competence, it creates a placebo effect. And placebo effects are our friend. It changes brain chemistry, and it's a much better way to proceed than treating out of fear or anxiety. So this was not this man's day to die. He went on to live, and many years later gave this man an award at the American Foundation for Suicide Prevention annual gala for his work in suicide prevention. This is Kevin Berthia, and this is Kevin Briggs. Kevin Briggs was a CHIPS highway patrolman. Kevin Berthia is now a well-known inspirational speaker. The two of them have a recording at the Smithsonian, and they're my buddies. Um, it's just a way of saying we can effectively treat and target suicidal risk. And we don't have to throw the kitchen sink at it. We should be using evidence-based practices, which is what psychologists were trained to do. And that is absolutely, in my view, in the patient's best interest. So with that, we will open up for discussion.
Hi there. Thank you so much for your presentation. I really appreciate the historical walkthrough and then the discussion of the pivot to really focusing on how we can prevent completion of suicide. So thank you so much. We have several questions and then several also just appreciations of gratitude for the presentation. So I wanted to make sure that I said that up front so that we didn't lose time in doing it later. But one question talking about some of the history and research. So you suggested a paradigm shift toward prevention-focused research. So what barriers do you see existing to conducting that prevention-focused research in suicidology? And then another question for how clinicians can contribute to prevention-based research or integrate those principles into practice.
Yeah, the barriers are really history and momentum. There's a lot of interest in social determinants and a lot of things that go more into the political realm, which these days is insane. But different kinds of things that we have college students now saying as a reason for dying that they'll never own a house, they'll forever be in debt. The earth is dying. We had a African American patient in one of our trials as a driver of suicide, racial and gender oppression. We're doing a study now looking at suicide status forms from 20 years ago to see if, in fact, we see these differences, but I think they're there. I mean, I can certainly say at the impressionistic level, we see larger forces in play with suicidal risk. But I think the upstream argument is one that is compelling, but I feel ambivalent about it. In many ways, people like primary prevention and like the 10,000, sort of programming and sort of policy initiatives, but avoid the clinical. And in my view, we don't have enough of this of this webinar that the trust and the board certified ABEP are bringing. It's like we wrote a paper about the zero suicide model called Zero Suicide, What About Treat? And it was published as an editorial because the zero suicide model is being widely embraced, but the treat is like an asterisk. It's like, oh yeah, we did CBT. Well, did you do CTSP or BCBT? No. Well, you really should be doing treatments that have been proven to be effective. So that's a long-winded response, but I really feel like there are many barriers, but a lot of the barriers are what we're used to, and the idea that we just like to get rid of these people versus actually engaging and working with them.
Yeah, I appreciate that reflection. Thank you.
I don't mean to be snarky about that. When I say getting rid of people, I think out of anxiety and fear of malpractice, we move quickly to have this person taken by a real doctor like a psychiatrist and think it's beyond our scope of practice. It's not. We can work effectively with these folks.
Yeah, well, I appreciate how you ended that and talking about, sometimes our gut response is to refer them to someone else, a psychiatrist or somebody else on the team. So some of the questions were really just about how to. So the first one, if you had to summarize tips for safety planning, how can clinicians ensure it's not a rote task, but truly collaborative between clinician and client?
That's a great question. Sit down next to them with permission, or do it on Zoom and have it be or DoxyMe or whatever your platform is. Have it really be collaborative. I mean, one of the things I'm certain about in that Pew Foundation Joint Commission study, when they are administering the safety plan, it's a nurse handing it to somebody out in the day room who's filling it out by themselves. That is not how it's intended to be done. And when they drill down in the survey data, they in fact saw that many of the safety plans were not done with adherence. So it really is meant to be collaborative. In CAMS, that's all it is. It's in the name, is that we engage in a collaborative way. We don't judge. We never furrow our brow. We never wave our fingers. We're just really trying to understand what it's like for this person and how they struggle. And when you do that, that's therapeutic in itself. So we have two published papers showing that the SSF is a therapeutic assessment. So this is a whole thing, if you're not familiar with this assessment research, that some of our assessments actually make people feel better. And the SSF is one of those.
Well, so some of what you're speaking about with assessments really does imply that the individuals who are giving those assessments need to have some expertise. So I just want to give acknowledgement to one of the comments that was saying, some of the things that we're doing, thinking that we're helping the cause of making an assessment for everybody to be able to do may also be, setting us back as well. And so really needing to think through how we train individuals.
Oh, totally. I would just say there are assessments, there are assessments. I was at Fort Hood in Texas where a social worker told me that soldiers are being asked about suicide risk 32 times a week. You're really missing the boat there. You're not, you've lost your efficacy when you're asking that many times. So you need to be thoughtful and competently trained to ask in a very sort of empathic way, and it will make a difference.
Right, thank you. Well, so one question is, how long does the CAMS assessment and treatment session typically take? And does insurance cover the entire treatment? And then also a comment with managed care nowadays, insurance does not allow for more than 50 to 60 minutes per session. And it seems to that person that the effect of a proper treatment plan that you're going to need more than that 50 to 60 minutes for the
Actually,
session.
no. It's a pacing issue, it's a training issue, but you can administer the first session of CAMS is pretty loaded.
Mhm.
But you can be done in 50 minutes. I can do it in 28 minutes, but then I invented it. So it really is a matter of getting used to it and pacing it. So it can be done in a 50-minute or 45-minute session. We see it all the time in the clinical trials. It's what we train to. And the typical modal response to CAMS is 6 to 8 sessions. But the one session version of CAMS actually, we got to replicate it and we need some independence and get an RCT eventually. But it is relatively easy to learn and relatively flexible in ways that clinicians can accommodate where they don't have to change their theoretical orientation or the interventions they know to do.
Well, so let me just allow you to give a plug for where people might be able to go and get that training, because that was also part of the questions that we saw too.
Yeah, on my disclosure slide, cams-care.com.
Yeah.
So CAMS Care is the only authorized training company. We do that for quality assurance purposes. If you know anything about DBT, there's a number of competing less than adherent DBT training organizations. CAMS Care really does try to manage that and keep the quality high and affordable. So for clinicians in training, there are resources that we make that are available for free. So if you're a professor, you work in a clinic or a supervisor, there are CAMS Care trainings and materials that we can make available for free. Young clinicians are great because they don't have attitude. They actually care about the evidence base and they get really good at this really fast. And so we have a colleague, Linda Moore, at Eastern Kentucky University, who has a PsyD program, a clinic, where she has 40 second and third year PsyD students who are experts in CAMS, and they are competent in the cases that people are otherwise terrified of, and they're in the third year. So it's really exciting to work with young people. People my age, it's a much tougher sell.
Great, thank you. Can you give some suggestions to increase the sense of a life worth living, help clients identify those reasons for living? They talk about Linehan's inventory is sometimes a helpful starting point, but too often inadequate when clients are hopeless and highly suicidal, especially considering the cognitive rigidity and critical thinking deficits that tend to emerge when clients are highly suicidal.
That's a
So,
great question.
again, what recommendations do you have? This person is really seeing the reason for living piece is really key.
Yeah, that's a great question. So we have two studies that were published out of Switzerland showing that in a first session, you don't want to focus too much on what the patient writes in terms of reasons for living or point reasons for living out, because that can be validating and shaming.
Mhm.
What we see in the course of 2 or 3 sessions of a little therapeutic traction, not complete resolution of drivers, but just a little progress, is there's an increased openness to their reasons for living that they might have identified in the first session. And then as they continue to make headway and they're more stable, it's an evolution. And then in the final sessions, like session 6 or 7 or 8, we might say, and so we can see that you're better able to manage your thoughts, feelings, behaviors, and you're more stable. But what could make your life worth living? And that's where we might get historical or might, really think about creatively. And to that end, I'm a huge fan of like The Midnight Library, which is a book written by Matt Haig about possible lives. I'm a big fan of existential philosophy. I taught a class this last semester in the psychology of living, and the first 5 classes were about suicide because we've learned so much about life from studying people that don't want it. So there's a lot of resources actually that we bring into the picture. We lean heavy into ACT, values clarification, and then committed action based on your values. with teenagers and find that's been really effective in kind of giving them some clarity about what's important to them and what they value.
Yeah, so I think this is a continuation of the last question, and you set it up beautifully in your discussion about Act Two. But can you speak to the importance of instilling hope? You know, that the single biggest effect of CAMS was increasing hope and uh, decreasing hopelessness. So what do you make of this finding, and what does this suggest about the importance of instilling hope? How might we more meaningfully and intentionally incorporate this into our assessments?
That's a great question. I would say you don't necessarily instill hope in your assessment. You instill hope in your treatment. What I mean by that is um, when we get to treatment planning in that first session, every interim session, we're coming up with all kinds of interventions to treat the drivers. And oftentimes in our first session, we watch the patient, and I'll say, okay, Andrea, for your isolation, I'm thinking group therapy, but we can start with sort of having a better relationship with your sister, so maybe some family therapy and some behavioral activation to that end, and probably some cognitive therapy, and then it also makes sense to me around the vocational issue, some vocational counseling, maybe an inventory, and when you start rattling off a bunch of interventions to treat this problem that makes this person consider suicide, you see a flicker. I would say in the majority of cases, you see a flicker and it's hope. You can
Mhm,
treat this? Yeah, we can treat this. We'll have to figure out what works for you and how it lands with you. But yeah, and if it doesn't work, we'll come up with something else.
mhm.
That's where the hope comes in.
Yeah,
That they
thanks.
see that there's more than one way to treat this problem that to them is intractable and is why they have to kill themselves.
Mhm. So last question. This is regarding the recent changes to the 988 suicide hotline. So recently read that 988 will be eliminating its specific subsection for LGBTQ plus individuals. Is there evidence that LGBTQ plus individuals are more likely to call hotlines such as 988 when they know that there is that specific option for them?
Not evidence for that, but there's evidence that this population is significantly at much more risk. The funding has been allocated for this. This is a political move that has nothing to do with the evidence or saving lives or decreasing suffering. It's going to increase suffering. It's unconscionable. The only sliver of good news I can share about this, because I was just on Capitol Hill this week meeting with members of Congress and their staff, is that there's a lot of dissatisfaction with this political move by the administration. I'm not saying it will be reinstituted, but it should be because it's a lifesaver. And the lifeline we know is effective based on Manny Gould's research and other studies about looking at the effectiveness of 988. So it should not be about politics. It should be about who suffers and how can we help them. And that the lifeline is a big part of that solution.